This is the 6th episode of the Paula podcast, and I thought it was a really good opportunity to touch base and review some of the things that we've already covered, and also to cover some new topics. These are what I'm going to touch on, obviously briefly, because we can't go into detail on all of these things, but we will put some articles that are relevant to what I'm discussing today on the Patreon. So I'm going to start with heavy menstrual bleeding. This affects probably 30% of women, but one of the problems is that individual women don't know what to compare what they have with what other women have. So it is the commonest referral criteria for gynecology. If a woman has a menstrual cycle, i.e. she's not using contraception and she's in her reproductive years, then bleeding can become unacceptably heavy. And I think the most important question you should ask your patient is, are your periods heavy? Are they heavy for you? And you might be seeing somebody who's presenting with iron deficiency anemia or breathlessness or tired all the time. So this is just really an opening into one of the very common causes of anemia, which can cause depression, and very many patients in primary care are now managed with antidepressants, but maybe we should be looking at underlying physical causes for their problems. I think it's really, really important to understand that most of the management and simple underlying investigations can be initiated in a primary care setting, whether that be by a GP, practice nurse or practice pharmacist. Just waiting for the slide to change. NICE have drawn up really clear recommendations as to how to manage heavy menstrual bleeding, heavy periods, with some treatment recommendations. So the guideline was updated fairly recently, and one of the most significant changes was around not blind sampling when you're doing an endometrial biopsy. So some GPs, particularly GPs who fit intrauterine contraception, would have been comfortable with taking an endometrial sample, but the current recommendation is that this should be done in a hysteroscopy clinic, generally speaking in an outpatient setting, but occasionally in theatre, depending on the individual woman's desires, and also it may be difficult or impossible to do to view inside of the uterus in an outpatient setting, but for most women that is possible. So first line treatment is a levonorgestrel intrauterine system. Both Mirena and Levocert have 52 milligrams of levonorgestrel in the core, and the devices with the most levonorgestrel will be most effective to manage heavy periods. There is also a reduction in bleeding with both Kylena, which is 19.5 milligrams of levonorgestrel, and also JDES. Second line treatments include tranexamic acid. Personally, I feel that the dose is often suboptimal. My recommendation is that women should use 1 gram 4 times a day for at least the first 4 days of their bleed. And this can also be combined with non-steroidals like mefenamic acid. And mefenamic acid or any other non-steroidal anti-inflammatory drug is best initiated 2 or 3 days before the woman's period is due if she knows that she's about to bleed. If your patient has no contraindications to combined hormonal contraception, then she should be able to achieve approximately a 40% reduction in bleeding. And Clara, which is a unique combined pill, has an additional licensed indication to manage heavy menstrual bleeding, and we can achieve up to an 88% reduction in median menstrual blood loss with Clara, which is very similar to what we can achieve with an intrauterine system with 52 milligrams of levonorgestrel in the core. So actually, for the very small minority of women who are not suitable or in whom it's not possible to fit an intrauterine system, if they have no contraindications, then Clara is a very good option. It's more expensive, but you will save on the reduction in referral to secondary care. And third line includes drugs like norethisterone. In the UK, we use high-dose norethistron, 15 milligrams a day, usually delivered as 5 milligrams 3 times a day. That has an estrogenic effect. So for women who are significantly overweight, then just remember it's very similar to a 20 microgram combined pill. So you will be increasing the risk of venous thromboembolism, which is already increased in association with obesity. That's the commonest significant risk factor. But there are other progestogens that you can use. Medroxyprogesterone acetate, 10 milligrams. You may need to provide the patient with 20 milligrams 3 times a day to stop bleeding. And you can also use norethistron fairly flexibly. In a woman who is bleeding heavily, she can be provided with 5 milligrams 4 hourly until her bleeding stops, and then 5 milligrams 3 times a day. And although it says there day 5 to 26, I think we don't need to get bogged down by those specific dates. Personally, if I was to use a drug, I'd find it very difficult to remember to do it on certain calendar days, and I think it's almost easier just to use it continuously, but that's not what you see in the BNF. So we've already covered this. This is a really useful opportunity to review underlying causes of heavy menstrual bleeding. And just to make the point again, that for most women, there is no physical abnormality. So the PAM-Cohen system, which was developed by Figo, divides causes into structural and non-structural causes, and the most common cause of heavy periods is ovulatory dysfunction. I mean, I think I've been through this on several of the podcasts already. So you may have a younger woman at the time of menarche who does not ovulate regularly, and again at the other extreme of reproductive life, in the perimenopause, ovulation becomes much less predictable, but there is stimulation of the primordial follicles, which will produce estrogen, cause the endometrium to proliferate, and it will often shed chaotically. Of the structural causes, we've got polyps, we've got adenomyosis, which is basically little bits of the lining of the uterus embedded in the muscle, making the uterus bulkier, makes the surface area to bleed from bigger. And it's very much linked to endometriosis, actually. It's just that the deposits are within the muscle rather than elsewhere in the peritoneal cavity. Leiomyomas are fibroids, and they are very, very common. So if you were to perform an ultrasound scan on all of your female patients, then probably somewhere around 8 out of 10 would have fibroids, very small fibroids, totally insignificant fibroids. These insignificant fibroids tend to be embedded in the muscle, and the ones that cause problems are the ones that distort the endometrial cavity and increase the surface area to bleed from. And then what we all worry about are hyperplasia and malignancy, and both of these things are becoming commoner in association with the rise in obesity. So they're not to be forgotten, but they're certainly not the commonest cause of abnormal bleeding. And then again, in the non-structural causes, we also have coagulopathies. So that might be things like von Willebrand's disease. And you can determine whether there's a risk of that from the history. So a patient who has von Willebrand's disease will have bled heavily since menarche, will have bled in other situations. So may have bled very heavily in association with tooth extraction or large loop excision, for treatment of cervical pathology, and in other situations where there's been trauma. Iatrogenic is where we've caused the problem, so that might be in association with a copper intrauterine device, and again that would also fit for the endometrial category. And then there's the not yet specified. So I think it's quite easy to remember that PAM-Cohen. Just think of a palm and a coin, and remember what those different potential causes are. So fibroids, you can see there looking straight at the uterus on the left side. It's really the right side if it was turned around, but on the left side of your screen, a small intramural fibroid, which will be irrelevant. And then there is on the right-hand side of the screen, a submucosal fibroid, which may well be associated with heavy menstrual bleeding. And that can be removed in an outpatient setting using a morcellator, which is passed down a hysteroscope. So These can be quite challenging because as you remove the more superficial part of the fibroid, actually there's often more below. But it's certainly an option for women to avoid the need for hysterectomy. And it's also really important that you're aware of the option of uterine artery embolization, because women should not be channeled down the route of a major operation when there was an alternative which would potentially have been associated with less significant consequences. We did have a drug called Esmia, which I'm sure you've heard of, and actually was a very good drug, a selective progesterone receptor modulator, which has now been withdrawn from the market because it was associated with liver failure, albeit in a small number of women, but there were a number of women globally, and 750,000 women were treated, so less than 10 women developed liver failure. But even with monitoring of liver function tests, there was a subsequent case of liver failure, and therefore the drug has been withdrawn as far as I'm aware. So these are the types of fibroids. That's an anteverted uterus seen on transvaginal ultrasound. Type 0 is a fibroid polyp. Type 1 and 2 are submucous fibroids. Type 3 and 4 are classical intramural fibroids, and type 5, 6 and 7 are all subserosal fibroids. Now, they normally don't cause any problem. They certainly don't cause heavy menstrual bleeding, but if they're big enough, they can cause pressure problems. So they may cause urinary frequency, difficulty voiding, and we're going to talk about problems associated with prolapse and incontinence a little bit later on. Menopause, I think we can never do enough menopause. So thinking really simply. The menopause is a deficiency state. Your ovaries are pre-programmed to last about 50 years, and most women have well outgrown them. So if your patient's thyroid ceased to function, you would give them thyroid hormone. So in otherwise healthy women, there is no reason whatsoever not to provide HRT. I personally think it's really important to check the blood pressure and the body mass index. Women who are hypertensive should have their hypertension controlled before they start treatment. Having a family history of breast cancer does not contraindicate HRT. It means your individual patient may be at a slightly increased risk of getting breast cancer. If she's unlucky enough to get breast cancer and she's taking HRT, then her end mortality is exactly the same, whether she did or she didn't have HRT. So there are numerous different symptoms associated with menopause. The classical symptoms are vasomotor, hot flushes and night sweats, but the less easily recognised symptoms include depression and anxiety. Women should not be offered antidepressants to treat the menopause as first line. And then aching, joint pains can be a problem. If women are not provided with HRT, they will lose 1% of their bone density annually. And therefore, many women post-menopause are likely to become osteoporotic. That may be associated with fractures and result in chronic pain. Women who don't have HRT within a window of opportunity, which is up to 10 years, who are otherwise healthy, will then have an increase in the risk of atheroma, because lack of estrogen is a cardiovascular risk factor. So I think an awful lot can be done in a menopause consultation, not just focusing on hormone replacement therapy alone, but also considering lifestyle changes. So has she got a healthy diet? Does she exercise enough? My recommendation would be small, healthy meals frequently. Nobody has to have anything excluded, but everything in moderation is better. Walking 150 minutes a week is really good. Yoga or Pilates are also very good for core stability and flexibility. So we've got short-term and longer-term consequences of estrogen deficiency. The longer-term consequences include osteoporosis and an increase in cardiovascular disease, but also urogenital changes, which we covered in a separate podcast. And one of the articles which I'm going to upload for you is an assessment of urogynecology in a primary care setting. And within that article, it very much makes the point that lack of estrogen locally has a huge impact on the urogenital tract, and women may suffer from recurrent urinary tract infections as a result, which actually has the potential to cost a lot of money and also has the potential to lead to sepsis, which can be fatal. Many women suffer from depression. Of course, that may be totally separate from the menopause, and therefore the history and the chronology of the history is very important. So some women will require not just HRT, but maybe require antidepressants in addition, and that sometimes makes all the difference. Politics of HRT, I think it's never a mistake to review that. It's now 18 years since the Women's Health Initiative was published in 2002, causing a huge amount of damage, and it just shows you what you can do with poor media coverage. So they reported a 26% increase in the risk of breast cancer, 29% increase in MI in the patients being studied, and a 41% increase in stroke. But what they didn't say was that many of these women were significantly older when they commenced HRT, and therefore they already had their own underlying cardiovascular risk. And if you consider the lifelong risk of developing breast cancer is 1 in 7, then the older you are, relatively speaking, the more likely you are to get breast cancer. But the reality with this study was that the numbers of affected women were actually very small. And only this week, the International Menopause Society have published the ongoing results from the study, which show a reduction in breast cancer in association with women using conjugated equine estrogen alone. I personally would not start somebody on conjugated equine estrogen now. I'd leave them on it if they were on it and they were happy, but my preference is to use body identical estradiol. So it's produced synthetically, but it's exactly the same as your patient's own estradiol. And very interestingly, using estrogen in women who don't have breast cancer is better at preventing breast cancer than tamoxifen. So I think that's very powerful. We know that in the combination arm, there was a very small increase in the risk of breast cancer, but no increase in end mortality. So I think that's very reassuring to women. I think there is still a huge amount of anxiety about causing harm to yourself if you're a woman by using HRT, and I think you can turn that on its head and explain to patients that actually they're more likely to cause harm to themselves by avoiding HRT if they are otherwise healthy. And it's really important to keep women in the workplace. Women of a certain age are propping up many of the bigger organisations like the NHS, the fire service, the police, and therefore it's really important to support them to develop a policy, but also to make sure that they can access treatment if they want to. And the NICE guidance made the point really clearly that menopause management should be individualised. We are going to do a podcast in the near future on managing the menopause in the workplace, and I'll also do another podcast looking at how to manage women who develop bleeding, particularly in association with continuous combined HRT. So we know that women ideally should have been 12 months from their last menstrual period before they start HRT. But even then, some women will develop bleeding, and that is to do with the combination and dose of estrogen and progestogen that's used. So this was developed for the Primary Care Women's Health Forum, really as a way of busting the myths. So on the left, you've got the myths, and on the right, you've got the actual facts. And essentially what this is saying is that care should be individualised. If you use transdermal estrogen, then you do not increase the risk of DVT. So my personal preference is to use transdermal therapy wherever I can. I think if we get this right, then more women will lose weight, and therefore their overall